There we go. Okay. So now it's not changing here. Okay. Righto. So just to remind you what the WHO guidelines are that Sassy's already spoken a little bit about, that for latent tuberculosis testing, you can either use a tuberculin skin test or a MAN2, or you can use what's called an IGRA or an interferon gamma release assay. And this is a strong recommendation, but the evidence is relatively weak, and this is a new regulation to the guidelines. However, it also recommends that people with HIV will benefit from preventative treatment if latent TB is diagnosed or if it's not. And so the recommendation is that LTB testing, latent TB testing, can be used when it's feasible to identify the individuals. And I guess the main issue here is where the burden of this disease is the greatest, the resources are also the least. And so often any delay to therapy induced by a diagnostic or monitoring test that isn't really point of care is problematical. And so LTB, it's a latent tuberculosis testing by either TST or IGRA is not a requirement for initiating treatment for latent TB in either people who are HIV positive or in child household contacts. So in resource-poor settings, although it would be nice to have these assays, it's not a necessity to treat people with HIV and TB or kids with the combined diagnosis of HIV in whom you suspect latent TB, or if they're in areas where TB prevalence is very high. The currently available tests have a number of potential shortcomings. There is the potential for intra-operator variability. There is the possibility of both false positives and false negatives, which compromise both sensitivity and specificity. And all the tests have some complexity of some sort associated with them. And so there is a need for a reliable, simple test for the screening of latent TB, both to facilitate contact tracing and risk populations, and to identify those in whom we might prioritise IPT. But as I said, where the need is greatest, the resource is also the least. So just going through some of the assays that are available and the pros and cons. So as Sassy said, the MAN2 or tuberculin skin test has been around for a long time. It's an in vivo test, and it consists of an intradermal administration of what's called purified protein derivative, which is a mixture of proteins. And the result is read 2 days later. So you have to apply the test by a needle intradermally, and then the patient needs to come back. So that's one of the phase of this test. Or if you're doing it in the community, the person that's reading it needs to go back to the households. And there is operator variability, both in terms of the application and in terms of the reading of the test, but this can be minimized and has been successfully minimized by extensive training and expertise of the nurses and healthcare workers that do this. There are false positives because of cross-reactivity with previous BCG and with exposure to atypical mycobacteria. But most algorithms for reading these tests incorporate an adjustment for things like previous BCG immunization. And then there is quite a high rate of false negatives that's particularly prone to false negatives in people that have an immunodeficiency or who are on immunosuppression or immunosuppressed for other reasons, such as diabetes or renal failure. And can be negative in people that have active TB, and particularly miliary TB, through this phenomenon called peripheral anergy. So the limitations of this test have then resulted in the quest for a simpler assay that's somewhat more reliable. As Sassy said, the response to TB is dependent on T cells and particularly on CD4 T cells. So this has led to the assays for the diagnosis of latent TB to be based around a T cell response. And I just want to spend a couple of minutes talking about T cells and how these things behave in a diagnostic lab. These assays are often done in either microbiological or in immunological labs. And those labs are used to doing serological testing. They're used to handling serum or plasma and often measuring antibody responses. Antibodies are among some of the most stable proteins that exist. And so we'll put up with a lot of handling, can be stored at 4 degrees for long periods of time, and will still give you a robust answer if you have a robust assay. T cells, although they look all right down the microscope, are very fastidious. They don't like being handled roughly at all, and they certainly don't like sitting at 4 degrees. In fact, they lose function. Once you do that blood draw, they lose function very, very quickly. And so if there is any delay in setting up the assay, you will get a reduced response. And in fact, we've done this in response to various antigens. In fact, when we were setting up the vaccine study here many, many years ago, we showed that the responses to HIV antigens, for instance, on an intracellular cytokine assay or on an ELISpot assay, if you did them immediately when you took the blood or did it 6 hours later, 6 hours later, the response had halved. 12 hours later, it had reduced a bit more, and if you did it beyond 24 hours, you weren't going to record much at all. So T cells need to be handled in a very different way from serum, and they need to be transported at least room temperature, and they need to be looked after. And that requires a completely different mindset in the laboratory. And even a laboratory that's used to doing flow cytometry for phenotypic characterization of T cells, such as doing CD4 and CD8 T cells, it's one thing to count the cells and when you're not wanting them to do anything except sit there and go through a flow cytometer. It's very different when you want those cells to actually do something, to respond to an antigen. And so, and the monocytes are actually just as prone to go off, in fact, possibly more so. And so the mindset of the technicians, of the nurses taking the blood, the people transporting the blood, has to be very different from what they're used to in doing quite a reasonable job with samples that are reliant on serum or plasma. And so this is a real challenge for functional assays. So if you lose any responses, often we're looking for very small responses. Even a large antigen-specific T cell response among T cells is usually trying to detect far less than 1% or perhaps 2% of the CD4 T cells. And so you're trying to count very small numbers of cells. And so anything that compromises your ability to count that very small numbers of cells then compromises your ability to get a positive result. And then if those people have already lost lymphocytes because they're on some sort of immunosuppression or because they're immunosuppressed, then you need to count even more cells to get your result above the threshold, or those cells need to produce more interferon gamma to get above the threshold. And so for an assay to work very well for any assay to work well in a diagnostic lab day in and day out, it has to be very simple and very robust. But in a T cell assay, this has to be even more so. And in a resource-poor area where you don't have lots of money to spend on quality controls, this requirement is even more desirable. So how might you approach this? So various approaches have been taken. As I said, if you look down a microscope at either the response in the lung or the response to a MAN2 test, the dominant cells that are responding to the TB antigens are CD4 T cells. So we want assays that measure CD4 T cells, and the traditional way of measuring CD4 T cells are things called proliferation assays, where you put resting cells in a well with antigen and in the presence of antigen presenting cells, and you sit them there for anywhere between 4 and 7 days and wait for them to detect the antigen and then start growing, proliferating, and then measure the proliferation either by incorporation of radioactivity or radioactive thymidine being incorporated into the DNA, or dilution of a fluorescent dye like CFSE. These assays have been used to monitor immune responses to a range of things, including primary immunodeficiencies, for a long time in pediatric labs. And the bottom line is, wherever you can avoid doing one of these assays, you should. They're very, very hard to standardize. They're absolutely operator dependent. They're dependent on the batch of serum that you have. They're very, very difficult to standardize, and most labs walk away from these assays as soon as they have an alternative. So then, as Sassy said, there's these interferon gamma detection assays, and there's two main sorts of these. There's the ELISpot assay, and for TB, the commercially available kit is something called a T-Spot TB from Oxford Immunotech. And then there's the quantiferon assays that now are distributed by QIAGEN. And the principle of these is very similar between the two assays, in that you mix, again, lymphocytes that have the CD4 cells among them and the antigen-presenting cells in the tube from the peripheral blood. You mix them with antigens, and those T cells hopefully produce interferon gamma if they're seeing antigen. And then you either detect the interferon gamma by an ELISA in the case of the quantiferon, or by something called an ELISpot in case of the T-Spot TB. And so there's been various versions of the quantiferon, which I'm sure we'll hear a bit more about later. And the most recent of these is called the quantiferon Gold Plus. And these certainly have been useful in replacing MAN2 and TSST, because in general they have better sensitivity and specificity. But because of resource issues and the lack of laboratory capacity, the TST remains the preferred method in many jurisdictions. So how do these things have better specificity than the MAN2? The MAN2, as I said, is a gamish of proteins derived from Mycobacterium tuberculosis. These assays are based on very specific antigens that exist in TB and don't exist in most other atypical bacteria and mycobacteria, except the list that Sassy's already shown you, and also don't exist in BCG. So you don't get the possibility of the false positive in people that have had BCG. And these antigens are called ESAT6 and CFP10. They're called RD1 antigens. And so this allows the assay to be much more specific for tuberculosis. It will still cross-react with those atypical mycobacteria listed there. And because these are peptide-based antigens, we're very good at synthesizing peptides to very high purity and reproducibility. And so the quality of the antigen is very easy to control. In any T-cell assay you want to set up, the most important thing is actually the quality of the antigen. If you have bad antigen, you will get bad results. And so the fact that you can synthesize peptides reproducibly at scale now in the 21st century has allowed the standardization of the antigen's presence in these assays to be very, very highly standardized and very, very high quality with very little batch-to-batch variability. But you are replacing multiple antigens that have been derived from the whole of TB with 2 quite small antigens. And so the T cells would normally see lots of epitopes from lots of proteins. Now they're seeing epitopes from 2 proteins, ESAT6 and CFP10. So in general, if you set up a quantiferon assay, like the original quantiferon assay that was based on TST, or you set up an ELISpot with TST, you'll get a big response. You get a much smaller response with ESAT6 or CFP10. So like everything, you sacrifice sensitivity for specificity. But the responses are much smaller, and then if people are immunosuppressed, then these assays have a harder time in being positive. So how do these work? Basically with the quantiferon gold, I think I'll leave this to the next speaker, but basically it's initially a whole blood assay. The antigen is added to whole blood in tubes. It's very small, it requires a very small volume of blood, and then after an incubation, the plasma is separated from the blood, and then the amount of interferon gamma in the plasma produced by the CD4 and CD8 T cells is measured by a standard ELISA technique. And although this assay has to be set up pretty much in real time at the front end, the back end, the ELISA part of the assay can be batched in that you can store the plasma and run multiple patients at the same time on the ELISA. So these are slightly old results now, but certainly in the original assays, it gave an indeterminate result in 6 to 11% of patients in published reports and up to 15% of samples in routine laboratories. I actually think it's actually not the assay that does this. I think it's the way the blood is collected and transported. And if you pay real attention to that, you can get 100% of these assays to work. And often these indeterminate results are the positive control failing to work sufficiently. But in our hands, if you have the nurse collect the blood well and invert that tube properly and get mixing, you'll get most assays working. It doesn't define the source of cytokine, though there is now with the new quantiferon assay perhaps a way of determining how much is coming out of the CD4s and how much is coming out of the CD8s. And it's used in an increasing number of routine labs. So ELISpots are technically demanding, particularly with respect to standardization. ELISpots, unlike the quantiferon, require the separation of PBMCs. So there's a first step where you get the blood to the lab and you have to do something like a five-hole separation where you get the PBMCs out of the blood, you wash those cells and you look after them throughout that time, and then you plate them out in essentially an ELISA plate, which I'll show you in a moment. And so the separation of PBMCs is time-consuming, labor-intensive, and technically demanding. And so you need you need skilled staff to do this, and you need staff that pay attention to what they're doing. You can stuff up PBMC separation very, very easily. I know I've done it on many occasions. And then because you've got to detect the spots and the cells are setting on a plate on a nitrocellulose membrane, you need a dedicated incubator for this, because if people are opening and closing the door, the cells get jostled around on that nitrocellulose and the spots will be blurry and you won't know whether the spot is a real spot or an artifact. And so the equipment for ELISpots is much greater. You need specialized equipment for the ELISpots, for ELISpot-based assays, both in terms of a dedicated humidified incubator, and you need either someone that's good at looking down a microscope and counting a spot versus an artifact, which means you need a really well-trained operator who doesn't get bored easily, because counting the spots is not the most exciting thing you'll do with your life. Or you need what's called an ELISpot reader, which is an expensive piece of equipment that does nothing else but read ELISpot plates. So it can't be used for anything else. So this is how an ELISpot works, or how I think it works. So this is a micro well. It's a well in a microtiter plate. The difference is that yellow line on the bottom, is either PVDF or nitrocellulose membrane. It's coated with antibodies that will bind interferon gamma, and the nitrocellulose is blocked with a just like you'd block an ELISA plate. And then you throw the cells in, the PBMCs, and the antigen, and hopefully they respond and they make interferon gamma. And the interferon gamma then hopefully binds to those anti-interferon gamma antibodies. And then you incubate that overnight so that the cells have time to produce the interferon gamma, process the antigen, and respond with the antigen presenting cells. So you incubate it overnight, wash the cells off, and so hopefully you've got interferon gamma bound to your capture antibody, and then you come in with your detecting antibody that's bound to a detection platform which produces color, and you produce a black spot. And they haven't shown up very well, but this is supposed to show you what the background looks like, and this is what the spots look like in the bottom of a plate. And you've got to be able to tell which one of those is a real spot and which one of those is artifact. So there is some skill to that. And you can see that if those spots become blurry by shaking an incubator, these things become difficult to read. So there is a commercial kit, as I said, that's based on this technology. It's a very highly standardized ELISpot. It's based again on antigens, the same antigens, CFP10 and ESAT6. It needs to be done real time. You need to separate, and you have to separate the PBMCs. You either read it manually or you need an automated a machine to read those. The advantage is that the interferon gamma is, as it's produced, doesn't get diluted in the plasma so much, it gets captured by the antibodies, so it's potentially more sensitive than the quantiferon. And in fact, a lot of assays in a lot of labs in the developed world, if someone fails a quantiferon, then they put it onto a TB ELISpot because they think that's more sensitive. But because this is more work, they don't want to be doing that as the routine test. And I've been through the other points. So, MAN2 test takes 2 to 3 days. The patient has to come back. It requires experienced nursing staff. The reading of the assay is somewhat subjective. It has a reasonably high false positive rate due to cross-reactivity and a high false negative rate due to active TB, immunosuppression, and age. The second generation interferon gamma tests that are based on ESAT6 and CFP10, which I've just told you about, take about 20 to 24 hours to a result, but they're often batched. It requires lab equipment, real-time setup within about 12 hours of collection. The result generation is automated, has a lower false positive rate because of reduced cross-reactivity. It still has a possible false negative rate due to active TB, immunosuppression, and age. And often these things perform worse in pediatric populations. And the comparison between the quantiferon gold and the T-spot TB is that this is a whole blood assay with a back-end ELISA. It's simple in preparation. It's a standard ELISA readout, so you can use your standard ELISA equipment, but it has a relatively high indeterminate rate. But again, I think that's due to the collection step. The T-spot TB requires separation of PBMC, so it's much more labor intensive. It's a complex sample prep, it's a complex readout, but it does seem to have greater sensitivity. Both need to be done real time. Positive and background controls monitor the assay interpretability, and a low positive control or a high background control results in the indeterminate or equivocal test. So the comparisons of these is somewhat difficult because, as Sassy said, there's no gold standard for the diagnosis. Both have a false positive, but far less than the MAN2, and false positive, false negative is less for the T-spot than the quantiferon. However, when head-to-head experiments of these two platforms are done, the concordance of the results is not 100%. And as I said, the earlier versions, so when you're reading the literature, you need to be careful because the earlier versions of the quantiferon had a higher rate of indeterminate testing, and also the very early versions of this were based on essentially PPD. So you need to be sure you're looking at data from the right generation of the test before you make your conclusions. They can both be negative in active TB, but less frequently than MAN2. So this is actually, I don't think there was this thought, but actually I think most of them actually stay positive after TB. And so I think some stay positive and some will become negative after treatment. So it's not a consistent observation. And neither will give you information in those with latent TB about those who are likely to develop active TB in the short term. So as Sassy said, we've developed an alternate approach to looking at CD4 T cell responses, where we can look at antigen-specific T cell responses on the basis of the upregulation and surface expression of two activation markers, CD134 and CD25, and CD134 is also called OX40. CD134 is a member of the TNF receptor superfamily. It's an important co-stimulatory molecule expressed on the surface of cells or upregulated on the surface of particularly CD4 cells, not so much on CD8 T cells. And it's transiently upregulated on activated CD4 T cells, and it's important in the generation of a memory response. And its expression is much more tightly regulated than other activation markers such as CD69. And CD25 is the alpha chain of the IL-2 receptor. It too is a co-stimulatory molecule, and it's expressed on the surface of T cells, both constitutively on Tregs, but also upregulated on the surface of activated T cells. So if you the issue is that these two molecules are upregulated on the surface of antigen-specific CD4 T cells regardless of their flavor. So it's upregulated on Th1, Th2, Tregs, Th17, and follicular T helper cells. So you're not dependent on cells producing a particular cytokine or guessing what the important cytokine is going to be for a particular antigen-specific response. And because of this, the responses are actually larger than you detect by intracellular cytokine staining or by ELISpot, because you're not measuring the response to 1, 2, or 3 cytokines, you're measuring the global response to any particular antigen. The responses are very specific. They're not bystander, and we've shown this extensively. And because you're counting the universe of CD4 T cell antigen-specific T cell responses, you're able to detect much smaller responses or absent responses. And therefore, it's particularly useful in detecting small and difficult to detect responses. And the other thing is that unlike with intracellular cytokine staining, where you have to punch holes in the membrane to get the antibodies in to detect the cytokine, you're not killing the cells. You don't need to fix the cells, at least immediately before they go into a flow cytometer. So you can actually then, if you have a safe sorting facility, actually sort those positive cells and characterize them either functionally or at the level of RNA. And it's simple and cheap. So how do you do the assay? Well, you take whole blood. You can also do this. You can do this assay on PBMCs, but you can do it on whole blood. So you take an aliquot of 200 to 250 microliters of whole blood. You put it in a tube or a well. You add another 250 microliters of tissue culture media with the antigen of choice, and you incubate for about 40 hours at 37 degrees and 5% CO2. And then you surface stain with CD3, CD4, CD25, and CD134. And this staining procedure we've tried to keep the same as how you do a CD4 or CD8 count. So very simple surface staining protocol. It can be run on either a 3 or 4 color flow cytometer. Denise Su has shown here in Thailand that you get exactly the same result whether you do CD3, CD4 identification of your CD4 T cells, or if you just do CD4 identification of your CD4 T cells. So you can drop CD3. So it can be done on a very simple flow cytometer. And you require about 3 wells. So you have your negative control, which is no antigen, your positive control. And we found that CD2, CD3, CD28 monoclonal antibody cocktail works best. But you can use staphylococcal enterotoxin B very easily, or PHA. It's just that PHA is much harder to get standardized batches of, and SEB is very hard now with the laws around bioterrorism. So it's staphylococcal enterotoxin B, and transporting SEB around the world to your colleagues can become problematical in terms of importing and exporting that from companies. So we've gone to this monoclonal antibody cocktail. We have a gamish of CFP10 and ESAT6 peptides, and we often include an antigen control. And because we work with a lot of HIV patients, we use CMV as that positive control, which ensures that things are being presented by antigen-presenting cells. So you gate on your lymphocyte population here by forward versus side scatter. You gate on your CD4 positive population. This is your background tube. You can see the advantage of using CD25 and 134 together is that you get virtually no background, and this is why this assay is so sensitive. This is your positive control using SEB. You get very large responses to CMV. So this is a nice antigen positive, antigen-driven positive control. And this is actually responses to the oncoproteins E6 and E7 in HPV, in someone with HPV disease. And the literature will tell you that you, by intracellular cytokine assay and without souping up an ELISpot assay, you can't detect these responses in the periphery. And I would put to you that there are responses there, and these results are published. So we can detect very, very small responses in the periphery. This is a response to PPD in someone that had active TB. This is a typical response to CMV. This is a response to Candida gamish. This is a response to TET-tox, to streptokinase, streptoguanase, and to flu antigens. So you can see it works across a number of antigens. And as I said, what this shows is that the response in terms of production of interferon gamma, this time in someone that's had a smallpox injection, or people that have had smallpox injections, and this is the the OX40 response. You can see that it correlates very well with the interferon gamma production, but if you look at this equation, there's about 8-fold as many cells detected by our assay as there are by the intracellular cytokine assay. And this is an example of an experiment where we've actually sorted the cells and then looked at, by single cell profiling, what the production of various archetypal transcription factors are to back up my claim that we're detecting all the sorts of T cells that respond to an antigen. So this is in terms of a CMV response. This is a response to TET-tox. And you can see that we're picking up Tregs by FOXP3, follicular T helper cells by BCL6. We're picking up TH2 cells and TH1 cells, as well as TH17 cells, and similarly with TET-tox cells. And so I might. So there's if you look at the responses of these assays against standardized results for the detection of MTB in people with active TB or people who are serologically positive for CMV, we get 100% correlation. We get recall responses to CMV, M. avium, and HSV1 are readily detected in healthy controls. And we can detect responses to things like GAG in late-stage HIV-infected patients. And we've shown that you can detect, again, very small responses, such as responses to hepatitis C. And in fact, the extent of those responses at acute infection correlate with the likelihood of someone clearing hepatitis C infection. And as I showed yesterday in the plenary, the responses to E6 correlate with the clearance or the regression of high-grade anal disease, intraepithelial disease driven by HPV. So they seem to be functionally important. And so we conducted this assay, this study a while ago now, where we went to determine the performance of the characteristics of the CD25 CD134 assay employing ESAT6 and CFP10 peptides in a population, basically a low prevalence population and a high prevalence population. We did 2 trials, one in Sydney and one here in Bangkok. And as I'll show you, the patients in Bangkok were all HIV positive. And we compared the results to quantiferon gold and the MAN2 test. And this was in the context of routine screening clinic for latent TB. And so in Sydney, we looked at 75 patients. In Bangkok, we looked at 50 patients. And we looked at both the sensitivity and specificity and the concordance of the results across the 3 assays. And so this is the patient populations in Sydney. In Sydney, they were all there was only one HIV positive, and most of them were being screened as contact tracing, or they were being screened for occupational reasons. In Bangkok, they were all HIV positive and being screened as part of their workup for their newly diagnosed HIV disease. Their median CD4 count was 188, but the range of CD4 count ranged from 10 to 350 CD4 T cells, and none of these patients were on therapy at the time of screening. And so this is just what these assays looked like. Again, lymphocytes, CD4. This is, this is Denise's work, and she showed that she could eliminate CD3. This is the background tube. This is the positive control, and these are typical E6 and CFP10 results. The results I'm going to show you are from the combined tube of ESAT6 and CFP10, but in the workup we ran those antigens separately as well. And so in terms of the comparison between CD134 and quantiferon gold in Sydney against a confirmed diagnosis of latent TB, both were 100% sensitive, and they had very similar specificities. And then these are the results of the 2 populations in terms of the comparison of the results here against the top lines against the quantiferon, and here against the TSST. And there was essentially between our assay and the quantiferon gold assay, there was a concordance of about 93% in Sydney and 90% in Bangkok. And the discordance between the 2 results really occurred in the HIV positive patients, where we were more likely to get a positive result, particularly in those people with low CD4 cells. Because we can count more cells in the interferon gamma, it's not dependent on what I think is the dilution of interferon gamma in the quantiferon. So it can be used, as Sassy has shown more recently, to detect TB and active TB as well. And this is a study that she did in a Thai population, median age of 42, with clinical diagnosis of either pulmonary tuberculosis or an alternative diagnosis confirmed. So these were all patients who were referred to these two clinics with a provisional diagnosis of active TB. They were divided between male and female, about 2/3 male. Some of them were presenting for retreatment, and about 1/3 of them were HIV positive. And so we compared, in this case, to the expert, and the take-home message is that the sensitivity is slightly greater than the expert, but the specificity is slightly worse. But in the extrapulmonary TB cases, which the expert can't detect, this assay was positive in 100% of cases. And in fact, in a recent study in an Italian group that's just been published, they found that this was a much smaller study. They found 100% and 100% specificity. So we didn't work with these people at all. I just discovered this paper doing a literature review, and these are the results for quantiferon. So it seems to work in active TB as well. I'll skip through that. So I think the assay is a viable diagnostic, and we're trying to build this into a standardized kit that's very simple to use, that uses existing equipment. If you've got a flow cytometer, it's adaptable in a lab that does routine CD4 and CD8 T cell counts, so we haven't got it adapted for the BITEC platform as yet. We've adapted it over the last year to be able to use a CO2. We can just use a heating block because we've found a media that allows us to do this in a CO2-free atmosphere and get exactly the same results. And it's very sensitive and able to detect responses in immunocompromised patients. And I'll leave it there.
Thank you, Tony.